Okay. Do you see my screen?
I see your lovely face. Now I see your screen. Yes.
Oh, okay, okay, thank you. Okay, now do you see that?
Yeah. So we are doing studies. We are done with
Okay.
observational.
Now we have done with screening, studies,
Mm,
observational. Okay,
right.
we'll do a rapid review. Okay,
Okay.
do a very simple rapid review. For,
Mm-hmm.
for for screening, we have said like once we draw a table.
Mm-hmm.
Okay,
Mm-hmm.
just those who have the disease and those who do not.
Sad. Right.
Okay, and
Mm-hmm.
the exposed, the same thing. This is, we call it like the golden table. We must master it. And those
Yes.
who have the exposed positive and those who do not. Okay,
Mm-hmm. Yeah.
the sensitivity, it's vertical or horizontal.
Sensitivity is the first column vertical.
Wonderful. This is the sensitivity,
Mm-hmm.
and this is
The specificity
specificity. The sensitivity, true, true, true overall,
divided by all.
true, true overall. Okay, just don't confuse yourself because of this thing are the same, true.
Mm-hmm.
Okay, true
Right. Divided by
overall.
all.
Okay,
Mm-hmm.
that's all within the circle, within this circle. Okay, within this circle. Now we will talk about the positive predictive value.
Mm-hmm.
Positive predictive value is the same
So
thing,
that's
true
divided by all.
by all. All mean just those two things.
Yeah. Those
Oh.
two.
And
Those that first row
yeah, negative predictive value, it's true
against true
overall.
divided by
Okay,
all.
okay. This screening test is really important. You
Mm-hmm.
will get a question on it 100%.
Mm-hmm.
Now we have mastered it. It's so easy, right?
Yep. Yep.
That's perfect. Okay. Now we will talk about the studies. Okay.
Mm-hmm.
Just a review about them. Review what we have already said in our previous discussion. We have said that this is the time, and
Mm-hmm.
this is at the moment. If we take a snapshot picture, okay, we take a snap picture. We call it cross section.
Mm-hmm.
Okay. If we take the exposure and see who develop the disease and who do not. Okay. See who develop the disease, who do not.
Mm-hmm.
What's we call this study?
If we're going in the future,
Yeah, in the future.
it's a cohort study.
Good, excellent. What if we take the disease
Mm-hmm.
and we see the
Then so that's the case control.
exposed positive and exposed negative? That's case control. Okay.
Mm-hmm.
Okay.
Yep.
That's perfect. And we have said earlier that once we construct the table, okay,
Mm-hmm.
it will be just like this. We
Mm-hmm.
put the disease, the same thing. The table is the same with the cohort and the control. The
Mm-hmm.
same concepts. Those are the disease. Those are exposed.
Mm-hmm.
Those are disease. They're exposed. Okay. Disease positive and disease negative.
Mm-hmm.
First of all, to solve any question about those, we just construct the tables.
Right.
Okay. And then we fill in.
Mm-hmm.
Okay. And then we fill the numbers in. Okay. Like an example, we take the and cohort. We take like 100 people who have the disease. Where we put this number? Here. Okay.
Mm-hmm.
We put it here.
Right.
50 of them exposed. We put it here. Okay. 50 of them, a number of people who do not have the disease. Okay, we put it here. Okay. He said that we construct the table and read the question. And
Mm-hmm.
anything he said, we put it in the table. Okay. Okay.
Yeah.
That's nice, right?
Mm-hmm.
And about the case control, the same thing. we use the, if we said that the exposed group like 200, we put it right here. Okay, who are not exposed 100. Okay, we put it right here, and then we see the disease said like 100 got the disease out of those 200. Okay, and like 70 got the disease out of those 100 who are not exposed. Okay, and that column we can, by subtracting, we can conclude it. Okay.
But in this one, aren't we like doing differently the case control? I thought this is how we do it for the cohort, where you put the exposed at the end. Exposed total,
It
non-exposed
doesn't
total.
matter. It doesn't matter. All what matters, okay? The matter is all the language of the question. Whatever the question tells you, that's the correct. Okay?
Okay.
Like if we said that in cohort, the disease population, like if we said like 100, okay? We can put it like this. And those who are exposed, it's 50. Okay?
Okay.
The people who do not have the disease, let's say 200. Okay? And those who are exposed out of those 200, we can say like 100. Okay, so once you get the question, the trick is that on those 100, those 50, the trick is to follow those rules. Number one, draw outlines of the tables, which is just like this. Okay, disease, positive, negative, and positive, negative, exposed. And number two, put on the, how would you understand the question? Fill on the tables, and then construct the laws. The law for the relative risk, put the numbers. Number two. Number three, put the laws. Okay, we can use the relative risk law and odds ratio. Okay, the relative risk, as I have said, the exposed over the unexposed. Okay, while the odds ratio A, D, B, C. Okay, just like this. Multiply those by divide them by the multiplication of those. Okay, while in the odds relative risk, imagine this table. I want you to get the relative risk. How can we get the relative risk from this table?
Which table? The one on the right or one on the left?
This one.
This one?
Yeah.
Oh, so then we said exposed or non-exposed. So the exposed are 50 plus 100, 150.
Yeah,
Non-exposed
exactly.
are 50 plus 100, 150. So that comes out to 1.
Yeah, so we can, with those people, the exposed, how many people are exposed in total?
So exposed are the first column. So 100 plus 100. I mean 50 plus 100, 150.
Wonderful. That's perfect. How many people who are not exposed?
150.
Exactly. Wonderful. 150. So what we are going to do, we measure the exposed over the unexposed. How many people who got the disease and those exposed, and the people who do not have the exposed. So what we are going to do, the relative risk, the exposed, how many people who got the disease out of those exposed, and how many people who got the disease out of the unexposed. Okay. Now the exposed, how many people got the disease out of those exposed? Can you?
50.
What? 50, right?
Yeah.
50 over 100, 150, right? How about those who unexposed? How many people got the disease?
Disease positive are 50.
Wonderful. 50 over 150, the same. Okay. So when we want to construct the relative risk, it will be just like this. 50 over 150, those are the exposed, divided by 50 over 150, those who are unexposed, right? Now the number will be 1. 1, what does it mean? Is that the relative risk between the exposed and unexposed is equal. Like there is no association between the exposure and the disease, right? That's what it says. You see,
Right.
with the previous example, we got the relative risk 3. That's it mean those who smoke are 3 times predisposed to the disease, which is COPD, like example, rather than those who do not smoke, right?
Right.
Okay, so this is the idea, right?
Got
The
it.
exposed over unexposed, right? We will review them one more time later, okay?
Sure.
Okay, now for now it's pretty easy, right?
Yeah, it is easy.
Okay, that's perfect. Now we should be able to answer any question comes about those topics, right?
Yes.
The question, the most important thing is that we don't panic when we come to a question. Just we understand it and just read it with a comfortable mind and calm and wisdom. We will get the best decision ever, and we will answer it in the best way. That's all about the biostatistics. Just we have a calm mind and take it easy. It will be super easy, and it is actually. Okay, so that's the observational mathematics, right? We will review them once we go to the confidence interval as well. Okay, just to make sure more. The clinical trial as well. We will do them one more time. The studies math is that what we have already talking about. Now we will complete it. Now the incidence and the prevalence. What's the incidence?
Incidence the new cases in a
Excellent.
population.
Like I'll give you a case. Like the incidence. There is a tricky question that comes to me about those simple topics. The incidence is the new cases overall at risk. This is very important, at risk. I'm sorry for this
No,
typing, but that touch is not good.
That's okay. I know what you're saying. What are you doing? That's
okay. Yeah, this is prevalence, all cases overall, all cases who are diseased, overall population, all pop, disease over pop. So I'll give you an example. The best thing to do that is by example, okay? There is, imagine like 100% in a population, okay? 20 got the disease, okay? From those 100, those who have the disease, from those 100, 30 died. Okay? So what is the incidence?
20 over 70?
Perfect. So that's perfect. It's pretty easy, right? What is the prevalence?
So we're saying all cases in this case is 20, if we're using the same example.
Yeah, the same example.
And total population. So that would be 100.
Yeah, so what will be the calculation?
20 over 100?
Perfect.
But those people are dead though. How can we still say they are all population? No?
And the prevalence, this apply. And the prevalence, like we can say this apply. We can say like those, whether those who died or those who have the disease, have the disease already. Let's say they have the disease already, okay? They have the disease already, okay? So those, as they have the disease already, we subtracted them from 100 in the incidence, okay? Let's say they have the disease, okay? That's not just died, not died. Okay, but in a prevalence, we do over the whole population, okay? So once you get a question about the prevalence, just sit back and relax, have a calm, peaceful state. You will solve that question 100%. Because it's easy, very simple. Just like take the total population, whatever say the total population, don't care with any other numbers, and take
Okay.
those who have disease, just divide them. That's it. But once you get the incidence, just subtract those who are died or who have the disease already. Okay? Because those who have the disease, they are not at risk anymore. This is this one concept. The second concept. The third concept that I want you to know, it's very important. I got a question in my exam on it. Is that the incidence? What is the relationship between incidence and prevalence?
Incidence and prevalence.
The prevalence, I'll let you. The prevalence.
If the prevalence goes up, the incident goes up.
Equal incidence multiplied by time. Okay, I got a question on that.
Okay.
In my exam.
Okay.
It's very important. It's not mentioned in the U word and anything, but it's mentioned in Kaplan. The prevalence equal incidence by time. He gave me the prevalence. Gave me the time. I remember it's 5 years. It was 5 years. He wanted the incidence. Okay, so once you have the prevalence,
divided by time, and you have the incidence.
Yeah, divided by time, you have the incidence. Okay. So that's all the three important concepts about the incidence and prevalence, right? So pretty sounds easy, right?
Yes, it does.
Okay, that's perfect. Okay. Now we have finished the incidence and prevalence. Okay. Now we will talk about the bias. In bias, we have a really important bias that is frequently asked in the exam. Do you see that? Okay. There is what's called Hawthorne bias. Do you know what that?
I think that's the observation bias.
Excellent. Perfect. Okay, that like there was a case in the U word who said that physicians, sorry, don't matter. Like doctors, let's say, monitored for taking sexual history. Okay, as they are knowing that they are being monitored, they change their behavior. Okay. That's what's called. There's what's called recall bias, right? Recall bias. What is that recall bias?
So if we go back and we ask the people, so they may or may not remember.
Yeah, if I ask you what's your dinner?
Yeah, what I had for dinner, I'll be like, I don't know, maybe tacos.
Yeah, that.
And I might eat pizza every day, but I'll just tell you I had a salad.
Yeah, so those what they have found that females who got like a baby with congenital malformation, when they asked them, they have you taken any drugs? They said yes. People who got a healthy child,
right,
they said no. Okay. This is recall bias. Okay.
Yeah.
That's all we're recall bias. Moms and babies. Okay, just remember. And there is what's called selection bias. Selection bias is that the most important part of selection bias called the attrition bias. When there's loss of follow-up.
Right.
Okay. You know what that, right? It's just like when we take 5,000 people who have the disease.
Right.
Okay. We end up having just 100. All the rest lost the follow-up. Just to make just like to make it funny for them. Sure. But just imagine that 4,000, just 1,000 lost follow-up. Okay.
Right.
This is what we call the selection bias. And there is what we call like measurement bias.
Mm-hmm.
It's not important. Let's focus on the measurement bias. Is just like when you have a defect in the measurement, or and like the device doesn't work well. That's it. Okay. Measurement bias and gathering on the scales, just like this. There is what's lead time bias. Very important. I encountered a question like that. An example. Lead time bias. Like we take people. Imagine 2003, 2016. Okay. The disease appeared at 2010. The people die at 2016, which happened in a prostate cancer. Prostate cancer, they got the symptoms, sign and symptoms at 2010. They die at 2016, right? Those same people, if we do a screening test, we discover the disease at 2003. Okay, we discover it. Okay, by the screening test, and that person spent 7 years without symptoms, but just having the disease. So what's the lead time bias? We thought that the screening test has prolonged the life expectancy of the patient, like from 2000 to 2016, but in fact it doesn't. Okay, it didn't do that. Okay, by just we have just discovered it earlier, but it didn't change the pathophysiology of the disease. They have died in the same time. Okay, so that's why in the prostate cancer we don't have a screening test due to the lead time bias, because we can't help it. Okay.
And there's also like this thing called like lag time bias or something, right?
Yeah, exactly.
And it's so confusing. I thought like they give the same example, and I'm like, I don't know how to differentiate.
Yeah, the lead time bias. This is the most important thing. The lead time bias is that the natural history of the disease is still the same. Okay, but just we discover it earlier. That's the lead time bias. Okay.
It doesn't change the outcome. They're still gonna die at 2016.
Yeah, they still. So why would we discover it and let them live with the stigmata of having it? They most commonly ask you about prostate cancer. Okay, that's why we don't have a screen test. So now there is what's called the confounding. The confounding when always when we want to illustrate the confounding, we draw a triangle, right? There is let's imagine COPD and smokers, alcohol. This is the commonest example for the confounder. People said that those people who drink alcohol got COPD. Do you think that's right? They have missed something.
Smoke. I guess people often who smoke, they also drink, or people who drink, they often smoke.
Yeah, exactly. So they thought when they made the study with alcohol and COPD, found people who have alcohol smoke, but then they found out that actually the alcohol is not the main problem. The people who alcohol always, like most of the time, they smoke, and the smokers, it's the one that caused the COPD. So what do you think is the one that confounder here?
Drinking.
Is Yeah, alcohol, you can't say alcohol and you can't say smoking. Alcohol is the one who confounded, because once we remove it, it appeared the truth is that smoking causes COPD, right? That's confounding. We have to differentiate confounding from another concept, which is called the effect modification. Now, the confounding is very easy concept, right? Very easy. By just a third criteria affect the causality. There's what's called effect modification. Very important concept. And effect modification is not a bias. We can't change it. Like, I'll give you an example. Like, people who have set a study from the size of shoe and the IQ. Okay?
Interesting.
Yeah, interesting. They have found the people who have a higher shoe size have higher IQ. And
Right.
in a school, and children, people, okay, who have high shoe size, they have high IQ. But in fact, it's not the shoes. The people who have high shoe size, they are, what do you think?
Taller.
It's older. Yeah, exactly.
Yeah.
They're older. That's why they got more high IQ, right?
Yeah.
So that's effect modification. Once we remove it, okay, that's effect modification. Effect modification is not a bias. We can't remove it. Sorry, we can't remove it. It's not a bias. It's
Right.
just a modification, just a connection, just like this. Okay. I've got a question. When the women who smoke, there's a connection between like pregnant females, okay, and DVT. But in fact, it was the smoking. Yeah. So once they have figured out the main issue is the smoking that caused the DVT. Is more risk factor for the DVT rather than the pregnancy. Okay, so that's the concept of effect modification. How to differentiate between them? The most important point is that the effect modification, okay, and the effect modification is not a bias. Okay, not a bias. We can't change it. Okay,
Right.
while this, once we clear our sites, we will see it clearly. Okay, so that's about the bias, right? There is one more low yield bias, which is called, there's what's called, it's high on this one, but Bernsen bias. Bernsen bias, when we take hospital ill people as hospital people. Like if we take people from hospital and study them, that's called Bernsen bias. Okay, because we miss the healthy people. We take just people in hospital and study them. We miss the total population. The hospital people don't don't represent total population. That's the Bernsen bias. Okay, and the healthy worker bias as well. We take the healthy people. It's the contrary to Bernsen bias. And the low yield bias is the following. Like there's bias which is called the procedure bias. Okay, the procedure bias, from its name, you will never miss such a question in the exam. Procedure bias, like in the operations that we are doing, not operation, like in our works, okay, and devices, just like this, in our procedure, we do a mistake, okay. Okay, that's the procedure bias. That's all the important thing about the bias. Like as a rapid review, Hawthorne bias. What's Hawthorne bias?
Observation. So if somebody is being watched, their behavior gets modified.
Wonderful. Recall bias.
So it just depends the I don't know. Let's just say somebody get a high score, they all of a sudden they remember, oh yeah, I studied MTB3 and therefore I have the high score. And there are people who don't have the high scores. They were like, oh, I should have studied MTB.
Yeah, that's perfect. How about selection bias?
So selection bias is just basically when we are not if we start out with, I don't know, 400 people and then in the end we only have 200 people who finish a study, so we
Excellent.
lose 200
Lead time
people.
bias.
So that's the one where the early diagnosis does not change the overall outcome of the disease.
Wonderful. And how about the Bergson bias?
So the Bernsen Bias, you said it was that the people in the hospital or nursing homes or any special population basically does not represent the overall population.
Perfect. And the effect modification and confounding. What is the difference between them?
Right. So the confounding is where we sometimes our results can get confusing. So is it the alcohol or is it the smoker? But when you take out the alcohol, then you realize that actually people who have smokers have a higher incidence of COPD.
Excellent. Perfect. How about effect modification?
So I have a quick question. How come the same example could be the pregnancy and smoking, right? Even though we know that pregnant women have higher risk for DVTs because of all this extra estrogen. But on top of that, if you're still smoking, then that also increases the chance, right? So how that can be confounding bias too, no?
It's effect modification called because there is two connection. The pregnancy is a risk for DVT and the smoking is a risk for DVT.
Well, in the confounding bias, there's only one thing that has a direct impact on.
Exactly. Effect modification, we can't change it. Okay, that's it. So that's all about the bias. Now we have done the screening, studies, study math. We have half of them, finish them, incidence and prevalence, bias. Okay, now we will talk about the fun part, the distribution. Okay, you ready for it?
Yes.
Okay, that's perfect. Now about the distribution, there is many types of distribution. There is what's called normal distribution. Okay, there is normal distribution, and there is what's called non-normal distribution, right?
Yeah.
Those are really easy and the easiest topics in the biostatistic and very easy to figure out. The normal distribution, it's called actually it's called the bell-shaped. Okay. Now we will talk about them in details. The non-normal distribution, there's three types. The bimodal, just like Hodgkin lymphoma or other cancers. And there is positive skewed, and there is negative skewed. Okay? First of all, we will talk about which one you would like to talk about first, normal or non-normal?
Not normal.
Okay, we will finish the non-normal first, and then we will talk about normal. The non-normal distribution, there is what's called the positive skewed distribution. Positive skewed distribution, it's the tail on the right. Okay, just like this, tail on the right. That's the important thing, the tail on the right. I want you just to know two important info about it. The tail, okay? Tail on the right. Number two, the mean is more than the median and more than the mode. Okay, that's the positive skew. That's all the two important info that you need to know about the positive skew. And negative skew distribution is on the contrary to this. So you don't need to memorize anything in here. Just the tail on the left, number one. Number two, the mean is less than the median, less than the mode. You know what the mode is, the most frequent,
right,
frequent value. The median is
is
like,
in the middle.
yeah, in the middle. But how if there is like, if there is 6 numbers, how to get the median? I'll give you an example. 1, 2, 3, 4. What's the median of this sequence?
I forgot. There's some
Okay,
rule.
we take those in the middle.
Oh, and make the average of those.
Yeah, 5 and 2. Okay, make
Divided
the
by
average.
2.
Okay.
So 2.5 is the median.
Yeah, but if it is, yeah, if it is 1, 2, 3, 4, 5, 3.
Then 3 is the middle. Yeah.
Okay, so that's it. The mean more than the median, more than, and it's actually it makes sense. Actually, it makes sense. With this positive skewed distribution, the mean will be here. Okay. Let's see. I will differentiate them according to the size, and the median will be just like here, an example, and the mode will be here. Okay. See, it's like, okay. So that's the, it's and it's so obvious, you can memorize it. Positive, it's more, okay, larger. Negative, smaller, okay, get smaller, okay. Okay, that's perfect.
Yeah. So basically, in both of these situations, we cannot use the mean. So it seems like median is a better choice, right?
Yeah. But sometimes, like, those questions about those positive skewed and negative skewed comes pretty straightforward.
Okay.
They can, like, I've solved many NBME questions and QBank questions. All what you need to know, they give you, they tell you that it's a positive skewed distribution, and which one is like mean larger than the median, or median larger than the mean. They give you choices within the choices. And what do you think is the correct choice?
That the mean is more than the median.
Perfect. That's positive skewed. And that comes to negative skewed. It's pretty straightforward. You will get them 100%. The issue is about the normal. And the bimodal distribution is just like this. When there is a disease distributed in the children and elderly people, old people, call it just like this. This bimodal, okay? This non-normal distribution, you should not worry about. You will get them correct 100%. Normal distribution, we need further details about them. Now we're going to discuss exactly. Normal distribution. That is the fun part. Hope you are not tired.
No, not yet.
Okay. Please let me know once you want to rest. Let me know so that we can.
Yeah, I will.
You want to rest 5 minutes before we start with the normal distribution, because there is more discussion.
Okay.
About.
All right. Let me just go get some water, and I'll be back in 5 minutes. So I'm just gonna mute myself.
Go bring some water and and keep smiling. The smile increase concentration up to 14 times.
Yeah, right. I'm gonna have you leave me a message on my voicemail, so when I'm freaking out, I can just like listen to you.
Yeah, exactly. I'll do that. Yes.
Okay, thanks. I'll call you in like 5 minutes.
Yeah, I'll be waiting. I'll do meditation till you come.
Yeah. Okay. Thanks. Bye.
Thanks. See you.